simple. It's like the body is like a container, right? So you have electrolytes and elements entering the body, and they're exiting the body, and then the body retains some of the elements. Like this includes sodium, potassium, magnesium, calcium, all elements, and there are different reservoirs. So, but sodium and potassium are very, very important because sodium and potassium maintain the osmolality, the electrolyte milieu. They are used important in neurological transmission, in cardiac activity, and now absolutely in everything. To maintain a good balance is very, very important. So today we are talking about potassium. So as usual, the entry is usually through diet. So the body acquires potassium through diet, and the exit is usually through, there are two main routes: the gastrointestinal tract, urine, and to some extent in the sweat. This elimination through sweat can be extensive in people who work in a very hot environment, like who are laborers working outside, or a chef working in a very hot kitchen, or marathon runners, for example. They can sweat a lot. They can sweat liters and liters of fluid, and they can lose a lot of electrolytes. So it's very important, but not to be forgotten. But usually, it's usually in the gastrointestinal tract and urine. The third most important thing to remember is that potassium is mostly an intracellular ion. So intracellular cation. So it and this, just like sodium is mostly an extracellular cation. So if there is a redistribution from the intracellular to the extracellular compartment, you can have a large potassium leak from inside the cell to the outside of the cell, which can be catastrophic. So that is also something to remember. So the total potassium, the entry and exit, and the redistribution determine what is the potassium that we are measuring in the blood. And one thing to remember is that there's a very narrow range of safety for potassium between 3.5 to 5.5 milliequivalents per liter. So the body has to maintain that balance. Okay. So as we described, 98% of the potassium is intracellular. It's a large reservoir with the change in extracellular potassium being determined by multiple factors, right? Just going to move this. Yeah. So there is sometimes you can have a transcellular shift with no change in potassium content. So the overall potassium content can be the same, but you will have redistribution from the intracellular to the extracellular compartment. In these situations, we don't want replacement. If there is loss of potassium, we don't want replacement in most cases. I'll explain one or two situations where you do need to replace, but we have to correct the mitigating events. So how do we manage the redistribution? How do you push the potassium back from the extracellular to the intracellular compartment? Like you'll graduate soon after your exams. You'll be working in the emergency. You'll have someone coming with an acute kidney injury and high potassium. So the things we'll discuss in detail later on. But just as a primer, we will look at some of the things that we can do. One is you can use insulin to move this potassium from the extracellular to the intracellular compartment. How does insulin work? It increases the translocation of the sodium potassium pump. What does sodium potassium pump do? It excretes 3 sodium in exchange for 2 potassium into the cell. So it takes 2 potassium ions into the cell, and it eliminates 3 sodium ions outside the cell. So there is always this ratio, this imbalance which is maintained by this pump. It is dependent on ATP, right? So there is movement of potassium into the cell and movement of sodium outside this cell, which is done by this sodium potassium ATPase pump, which is probably the most important pump in the human body. So the other event that can cause shift of potassium from the intracellular to the extracellular compartment is metabolic acidosis, where there's movement outwards, which is something we don't want. Now, what are the ways in which we lose potassium? As we discussed, it can be renal loss. When, like, for example, somebody is taking a lot of diuretics like furosemide or loop diuretics or thiazide diuretics, we tend to lose a lot of potassium. Or someone has got a lot of vomiting or diarrhea, because all these gastric juices and the bowel fluid has a large amount of potassium. So if you lose diarrhea constantly, you find that patients who are coming in will have very low potassium. And again, as we discussed, you can lose a lot of potassium in your sweat. Cyclist, chef working long hours in a hot kitchen, or somebody with cystic fibrosis who don't have the mechanism of saving the potassium. Okay, so what are the most important manifestations of, and why is it important? So both hypo and hyperkalemia can cause cardiac arrhythmia. That is probably the most important thing, that is life-threatening. It can also cause neurological problems like skeletal muscle weakness and paralysis. For example, patients are presented with what looks like a snake bite or myasthenia, and then we check the potassium. The potassium is measured at 1.5 or 2, where the only reason why then they have muscular weakness is because of low potassium. Now, what are the ECG changes? So the ECG changes basically are, you will find that you start developing an ST depression. The T wave starts flattening, and you start developing a U wave. And most importantly, you'll find that the QT interval starts prolonging. So the QT interval prolongation happens in hypocalcemia, hypokalemia, hypomagnesemia. Wherever there is a hypo, the QT prolongs. What is the problem with the long QT syndrome? It precipitates ventricular tachycardia and subsequently ventricular fibrillation, which again is life-threatening. Okay. So to simplify, hypokalemia, we can divide it into cardiac manifestations and neurological manifestations. When do patients manifest with hypokalemia? So you have a normal range between 3.5 and 5.5. They don't have symptoms unless it drops below 3. You start getting muscle weakness probably when the potassium is less than 2.5, especially if it's acute. If it's been chronic, patients are able to overcome the symptoms. They may not understand the symptoms, but if it's an acute drop, they start developing muscle weakness, cramps, and sometimes you can have muscle breakdown like rhabdomyolysis, because the muscles are struggling to function in a low potassium environment. Then again, muscles become very weak. Obviously the diaphragm also is a muscle. You need the diaphragm to breathe. You can have respiratory muscle weakness. Then you have cardiac arrhythmias. The things like atrial tachycardia, junctional tachycardia. Whenever you see any ECG abnormalities, the first thing you need to look for is electrolytes. You need to make sure that the electrolytes that are most important are potassium, the calcium, and magnesium. So you can have atrial tachycardia, junctional tachycardia, AV block, ventricular tachycardia or fibrillation, which obviously VTAC and V fibrillation are the most serious and life-threatening arrhythmias. That is where you'll have to shock, provide a DC cardioversion. Some of the ECG abnormalities which can happen even before all the serious arrhythmias happen are premature atrial complex or PAC, premature ventricular complexes, sinus bradycardia where the heart slows down. You can have ST segment depression, decreased amplitude of the T wave, and increased amplitude of the U wave, which we described before. Now, this is you probably want to, when you check somebody's potassium is low, you would definitely want to do an ECG first. So you'll see all these things in the ECG. You start correcting the potassium. Now, the other thing is to understand, why did this person develop hypokalemia? What is the how do you assess where is this potassium loss happening? You can have patients presenting with diarrhea, but you can't confirm that the gastrointestinal loss is the cause of potassium loss unless you do some tests, because they may have a combination. They may be taking diuretics, they may have a bit of diarrhea, they may have a bit of vomiting. You really have to do a urine test to find out whether the loss is through the renal tract or through the gastrointestinal tract. So you can use a simple algorithm here. We'll just focus on some of the important bits of the algorithm. I'll move this around here. Yeah. So what you can see here is you look at the urine potassium excretion. So if the urine potassium excretion is less than 15 millimoles per day, then or more than 15 millimoles per day. So if somebody is coming with low potassium and the urine still has more than 15 millimoles per day, you start thinking that the most likely losing potassium through the renal tract, because the job of the kidney is to reduce potassium elimination if the body is running low on potassium. But if you're losing potassium despite having very low potassium in the blood, then you start thinking that there is something wrong with the kidneys. So let's go along this limb of the flow chart. You'll find that you look at if the urine potassium is more than 15 millimoles per day, you assess the potassium excretion. Then you can look at something called the TTKG, or the transtubular potassium gradient. Now, we don't need to use it all the time, especially if you find potassium is very quite high, then you really don't need to use it. But this is to kind of help you find out the subtle differences between, to confirm that it is a potassium loss coming from the kidneys. So a TTKG more than 4, TTKG is calculated by looking at the urine potassium into serum osmolarity divided by serum potassium into urine osmolarity. It's basically a formula to find out if the loss of potassium in the urine is more than what you would expect in someone with hypokalemia. And then the first thing is to identify that, and then you look at the acid-base status. If the patient has got metabolic acidosis, you look at these conditions like diabetic ketoacidosis or types of proximal or distal RTA, renal tubular acidosis. These are conditions where they lose a lot of potassium in the urine and they are acidotic. But on the other hand, if they're alkalotic, which means if the pH is more than 7.45, and they then look at whether they have hypertension, because this is all this, as we go to subsequent slides, you'll understand why we're talking about hypertension. Because hypertension and hypokalemia, you start thinking of a set of conditions. Hypotension or normotension with hypokalemia, you start thinking of different set of conditions. If they have hypertension, you start thinking of mineralocorticoid excess or Liddle syndrome. Basically, if they have an excess of adrenal activity, you will find that they have high blood pressure and low potassium. On the other hand, if they don't have hypertension and the blood pressure is low, but they're alkalotic, which means that they're clinically very dry. Because when you're very dry, what happens is you have a normal response of aldosterone. Your aldosterone kicks in to retain sodium and to retain water. So then you start thinking whether they had vomiting or other conditions like Barter's syndrome, or whether they were using diuretics. Some of them abuse diuretics, use more than what is required, or if they have hypomagnesemia. So these things to remember here are whether there is more potassium excretion. You don't even have to worry about the TTKG. Just look at the potassium. If the potassium is more than 15 millimoles per day, if they are acidotic, you think of RTA, renal tubular acidosis, or any drugs like amphotericin, or diabetic ketoacidosis. On the other hand, if they are alkalotic, see if they have hypertension. If they have hypertension, you start thinking whether they have aldosterone excess, like like an adrenal nodule. But if they don't have hypertension, you start thinking whether they have had recent vomiting, diarrhea, and they are dehydrated. So that kind of, if you follow this protocol, you'll definitely come to a diagnosis. Now, on the other hand, if the urine potassium is less than 15 millimoles per day, which means the kidney is doing the right thing, it is trying to retain potassium when the body is running low, which is what a normal kidney should do. You look at the acid-base status again. If there is metabolic alkalosis, you start thinking that these patients have been using them diuretics and they're not letting us know. Or they've used it like 3 or 4 days ago and the kidney is recovering. Because when somebody is taking diuretics, the urine potassium will be high. But when they stop it, after 2 or 3 days, their urine potassium will become normal or low. On the other hand, if they have acidosis, you start thinking whether they have had any diarrhea or vomiting. Because why do you get acidosis when you have diarrhea? Because your pancreatic enzymes and your biliary secretions have a lot of bicarbonate. And you have chronic diarrhea, you lose all the bicarbonate and you become acidotic. You also lose potassium. So this algorithm will kind of, if you follow it very strictly, you will kind of reach your diagnosis at some point of time. So just a little bit more detail into the urine potassium excretion. So to make it more simple, if you have someone with low potassium, you can look at the urine potassium to creatinine ratio. If it's less than 1.5 milliequivalent per millimole, then it is not a renal loss. On the other hand, if the potassium to creatinine ratio is more than 1.5 milliequivalent per millimole, then you think that despite having a low potassium, if the kidneys are losing potassium, then the kidneys are at fault. Then you have to identify what is driving the potassium loss in the kidneys. So now we come to the most important hormone in this, which is called as aldosterone. And why is aldosterone important? Because I'll go to the next slide and then come back to this slide. So the aldosterone, this renin angiotensin aldosterone system is the system which maintains the blood pressure to a large extent in the, it's a hormonal limb of maintaining blood pressure, right? You have the sympathetic chain, which helps in maintaining blood pressure. Then you have the adrenal gland. So renin uh, converts angiotensinogen to angiotensin 1. Then there is angiotensin converting enzyme which converts angiotensin 1 to angiotensin 2. Um, and this angiotensin 2 then acts on aldosterone secretion. So this is the renin angiotensin aldosterone axis. So going back to the previous slide, where does aldosterone act? So aldosterone acts in the principal cell of the cortical collecting neuron. So if you look at, if you remember the diagram of the nephron, so this is the distal part of the nephron, right? So this is where you have a special channel called epithelial sodium channel. So ENaC, we call it ENaC in short. So this ENaC is controlled by aldosterone. So what it does is, if you're dehydrated, what happens is the body wants to retain sodium. So what does the body do? It takes sodium and gets rid of potassium. That's an exchange, and that happens through this channel. So this aldosterone acts on the nucleus, and it helps in retaining, pulling sodium in. Right. So the ENaC channel is mainly to just absorb sodium. Now this ATP pump here wants to take the sodium into the body, but it wants to eliminate potassium in exchange. So it takes 3 sodium into the body and gets rid of 2 potassium. So when the body is in an state of aldosterone excess, which can be because of a response to dehydration, or it can be a primary response without any stimuli, but the net effect is retention of sodium and loss of potassium. So that is why aldosterone is very important. It's a very important hormone, and it maintains the balance between when you're dehydrated, it helps in maintaining your blood pressure, it helps in retaining sodium, and helps in keeping the body's homeostasis. But sometimes when it overacts, that is the time when you start having high blood pressure and low potassium combination. Okay. So again through the slide. Okay, now let's look at 2 situations. One, when there is a normal aldosterone response. So when there is a normal aldosterone response, when do you have a normal aldosterone response? You have a normal aldosterone response when you are dehydrated, or when your aldosterone, when angiotensin aldosterone axis is activated. So this ENaC activity is increased due to the release of aldosterone in response to low effective arterial blood volume. So for example, if someone has an episode of vomiting or diarrhea and they're losing volume, then what they do is the body responds by increased renin secretion, increased angiotensin 2, and finally an increased aldosterone. The aldosterone helps in keeping the blood pressure up, and it does that by retaining sodium and getting rid of the potassium. Okay. So that is a normal response, where your blood pressure is normotensive or even low blood pressure. So that's a normal response. Once the aldosterone has achieved the objective, then it will slowly settle down. However, there are situations where your aldosterone response is abnormal. So this is where the abnormal aldosterone response continues to propagate potassium loss. So here you will find that usually you have hypertension associated with hypokalemia. So if someone comes to hypokalemia for a long period of time and they are hypertensive, you start thinking of these conditions. So think of conditions like renal artery stenosis, malignant hypertension, or renin secreting tumor, which is very, very rare. Among this, the most important is renal artery stenosis. So where what happens is, because of the renal artery stenosis, there is increased renin secretion and there is increased renin stimulus aldosterone. Unless you correct the renal now we know that almost 3 to 10% of patients with secondary hypertension have primary hyperaldosteronism, which means there is an adrenal adenoma which secretes aldosterone, or sometimes there is bilateral adrenal hyperplasia. Now, these are the conditions which you don't really have to think about now, but you just to know that Sometimes cortisol does not act like aldosterone because there is an enzyme which inhibits cortisol. But sometimes when that enzyme is inhibited, what happens is the cortisol acts like, if you remember your physiology, cortisol comes from the zona glomerulosa, which is outer layer, and the aldosterone comes from the middle layer. So the aldosterone is more to do with maintaining blood pressure, whereas cortisol is more to do with your glucose metabolism and water metabolism basically. And there are conditions like, rarely conditions like Little syndrome, where your ENaC channel is inherently overactive, which means that whatever you do, you continue to retain sodium and continue to have high blood pressure. Okay, so things to remember. Two important takeaway messages from this one. You can have a normal aldosterone response, which is in which situation you have a normotensive or low blood pressure, or you can have an excessive aldosterone response where you usually have hypertension. Then you start, when you see this combination, you start thinking of all these conditions. And this is again in the context of hypokalemia, but a patient having hypertension where there's a primary reason for the hypokalemia and the hypertension. Next, just a small word on cortisol and aldosterone, just as we discussed. Cortisol to aldosterone ratio is usually 100 to 1. However, cortisol does not cause aldosterone-like effects like hypertension or hypokalemia, because there is an enzyme called 11 beta hydroxysteroid dehydrogenase. It usually inactivates cortisol in the principal cell of the cortical collecting duct. However, when there is cortisol excess, like for example, somebody's got Cushing syndrome, you have the cortisol is more, it increases more than 100:1. It becomes, you have an excess of the cortisol. When this enzyme is saturated and the cortisol escapes degeneration and acts like a mineralocorticoid. So cortisol starts acting like aldosterone when there is a large amount of cortisol. Now, other situations like licorice, which we don't have in India, I think, when the enzyme is inhibited and cortisol can act like an aldosterone. So any situation where there's excess of cortisol, or when this enzyme, which is 11 beta hydroxysteroid dehydrogenase, is inhibited, what happens is the cortisol starts acting like aldosterone and contributing to high blood pressure, which does not happen normally. Okay, so generally, the hypokalemia is usually secondary to gastrointestinal loss. So the questions you start asking are, have you had vomiting, diarrhea? It can be because of urinary loss, because sometimes patients continue to use diuretics. You put someone's come with cardiac failure, you put them on furosemide, they become very dry, they lost all the fluid, and they lost all the potassium as well. Or rarely you can have renal tubular acidosis, which usually is a very rare genetic condition, but can happen. Or it can be an acquired condition as well. But you should also think about coexisting electrolyte abnormality like hypermagnesemia, hyperaldosteronism, as we discussed. If somebody has hypertension, if somebody's been on excessive insulin therapy, what happens is, as we know, insulin pushes potassium from the extracellular to the intracellular compartment. Or if they are on beta 2 agonists like puffers or inhalers, then that again pushes the potassium from the extracellular to the intracellular compartment. Or if somebody is very alkalotic, like they're dehydrated, or if they're taking medication which causes alkalosis. Now, what is the indication for replacement? Do you have to replace for everybody? Only if there is a true potassium loss, like if they are lost through vomiting or diarrhea or through urinary loss, and there is a significant deficit in body potassium. We'll see what is the definition of a significant deficit. And remember, when in redistributive disorders, we did not want to give potassium, but in certain situations we do give potassium, especially when there is a condition called periodic paralysis, where what happens is, because of sudden stimulus, it's again a genetic condition, the potassium, for some reason or other, shifts in mass from extracellular to the intracellular compartment. When it shifts from the extracellular to the intracellular compartment, what happens is your potassium drops catastrophically and can be very serious. So even though the total body potassium content is not any different, we still have to give them lots of potassium supplements so that their extracellular potassium remains stable till at least the crisis period is over. After that, you can stop it. So how do you calculate potassium deficit? So basically, if you have a reading of between 2.5 to 3.5 millimoles, then the deficit is usually around 100 to 200 millimoles. When it's between 1.5 to 2.5, usually the deficit is around 200 to 400. The one thing to remember is we cannot ever determine the exact deficit, as potassium is intracellular. So the intracellular compartment is a large compartment. We never know what is the exact potassium deficit, but this is just rough rule of the thumb. You can simplify it by saying that what is a goal potassium and a serum. For example, your goal potassium is 4 and your serum potassium is 2.5. Then that difference is 1.5 into 100, which is 150, divided with serum creatinine, which in your case would be, let's say, around 1. So basically, 1 is probably normal serum creatinine. So the deficit is 150 milliequivalents, which you will supplement over a period of a few hours. So what is the preferred agent? Potassium chloride is the preferred agent. Most patients with hypokalemia and acidosis are also chloride depleted. So that is the most preferred agent. It raises potassium at a faster rate, is available as a salt substitute, liquid, slow release tablet or capsule, and IV. So sometimes things to remember are hypokalemia can be an acute phenomenon. It can be a chronic long-term phenomenon. If it's a chronic long-term phenomenon, there are patients who are on potassium tablets for years and years and years. And things to remember about intravenous replacement is in the peripheral line, you can only give 10 milliequivalents per hour. And in a central line, like through a neckline, through the internal jugular vein, you can give it at a faster rate, which means practically if you have a patient who's got very severe hypokalemia, they need to go into the intensive care unit and they need to have a central line inserted for faster potassium supplements. Now, potassium bicarbonate, citrate, or acetate can be used in patients with hypokalemia and metabolic acidosis. There's other preparations of potassium. Potassium phosphate, very uncommonly used. So first, for example, you have something like Fanconi syndrome, where it's a proximal tubular disorder where you lose a lot of elements, including potassium, phosphate, magnesium. You can supplement potassium and phosphate by using potassium phosphate. Now, what are the adverse effects? Because the peripheral therapy, the reason we can't give much faster than the central line is because if there is an extravasation, it can cause painful phlebitis. Potassium is osmotically active, can increase tonicity of IV fluid, which is not a big issue. Sometimes if you give too much potassium, it can cause hyperkalemia. So when you're replacing, you should make sure to check potassium 2 to 4 hours later, just to make sure that you're replacing adequately and the potassium is improving, and to also make sure that you're not giving excessive potassium as well. Now, what is the goal of therapy? You're not trying to replace it completely. Your aim is to prevent life-threatening complications, like especially the cardiac arrhythmias. Now, the urgency of replacement depends on the severity, the rate of decline, and comorbid conditions. So if it's declining very fast, then you have to replace as fast as well. And elderly, you may have to consider replacing it slowly because they really don't have the ability to manage wide flux in electrolyte disturbances. And if you have underlying heart disease, again, you may want to replace under a cardiac monitor because small changes in potassium can cause cardiac arrhythmias. You want to make sure that the replacement is regularly monitored, and to make sure that you're not replacing excessively or under replacing it. One thing to remember is with digoxin or antiarrhythmic drugs, with digoxin, if you have digit toxicity, you have a risk of hyperkalemia. So if you're having digitoxin toxicity and you're replacing potassium, you just have to make sure that the potassium replacement is not excessive. So to summarize, hypokalemia assessment starts with first history. What is the history? What is the presentation? Is it because of a volume loss? Are they have they been running? Have they lost a lot of sweat? Have they had any vomiting or diarrhea? Or do they have redistribution due to other conditions? Like, are they severely alkalotic? Are they dehydrated? Or have they taken any medications? Like, have they taken excessive insulin? And those are things to look for. And in the examination, look at the volume status. So if they are dehydrated or high, which is most common likely clinical presentation for you, the easiest thing to do is supplement fluid along with potassium. Rarely you can have hypervolemic patients with the hypokalemia, especially somebody who has got an aldosterone excess or somebody with Cushing syndrome. They usually are not dry. They are probably carrying more fluid and they are hypokalemic. And that's a clue that it is an endocrine issue rather than something else. And again, the blood pressure is also a key. If you have low blood pressure, it means that they are dehydrated. If they have normal or high blood pressure, if they have high blood pressure especially, you start thinking of aldosterone abnormalities. Urine is very, very important, as is always in renal medicine. You want to make sure that the potassium loss in the urine is through the urine or through the non-urinary loss. So if you find that someone with hypokalemia has got lots of potassium in the urine, it is very, very likely that the loss is through the urinary tract. On the other hand, if the kidney urinary potassium is very low, it means that the kidney is responding appropriately. Again, acidosis or alkalosis will also point towards the cause of potassium loss. Somebody with alkalosis and low potassium, you start thinking of hyperaldosteronism. Somebody with acidosis and hypokalemia, you start thinking of things like Barter's or Gentleman syndrome. Or somebody who's had more likely to have had gastrointestinal loss like diarrhea. Vomiting causes alkalosis, diarrhea causes acidosis. The extracellular to the intracellular compartment. And also prednisone will also cause, prednisone mostly causes acts like aldosterone and causes renal loss of potassium. In patients with hypertension and persistent hypokalemia, always consider primary hyperaldosteronism, because up to 3% or even 10% of cases, depending on various reports, can present with secondary hypertension have hyperaldosteronism. Now, before we move to hyperkalemia, do we want to does anyone have any questions? I don't have any. Let's see if I have a chat screen open.
No, sir.
Okay. So it's all good. So let's carry on with the hyperkalemia. So hyperkalemia is fairly easy. It's not as complicated as hypokalemia, because hyperkalemia is usually in the context of it's basically, if you again look at the first slide, you're going back to the first slide. It's potassium. If you look at the physiology of potassium, put it very simply, it's entries through the diet, exit is the gastrointestinal tract, urine and sweat. Redistribution is intracellular, extracellular. So the potassium is shifting all the time. Now in hyperkalemia, most likely it's in the context of renal dysfunction. So if you have somebody with hyperkalemia coming to an emergency, you most likely will have them, you will notice that they have kidney dysfunction, either acute or chronic. So coming back to this, so usually in the context of renal dysfunction, because your elimination is affected. So they are taking food which is normal or rich in potassium, but they're not able to eliminate the potassium. So potassium tends to accumulate. Rarely you can have somebody with a lymphoma or a leukemia who have a tumor lysis. You give them chemotherapy, all the cells break up, and what happens is all the potassium from inside the cell just comes right into your extracellular system, right? The third possibility is somebody has got poisoning, or they got diabetic ketoacidosis or acidosis because of something, some medication or ingestion of some toxins. What happens is, because there is an acid milieu, there is movement of potassium from the intracellular to the extracellular compartment. Now, it's easier to understand and manage than hypokalemia, because hypokalemia you'll have to do a lot of assessments, but hyperkalemia is probably more easier to manage. So again, let's go to the most important thing. What is the problem with hyperkalemia? Hyperkalemia, the cause, if it's left uncontrolled, it causes cardiac arrhythmias, and that is usually the cause of death. So if you want to look at the P wave changes here, you'll find that the P wave changes, usually you start having, this is normal P waves, the P waves start flattening and the PR interval starts getting prolonged. And then finally the P waves disappear, and what happens is the sinus node is not able to function. So then if the sinus node is not able to function, then the next node that takes over is the AV node. So you find that the P wave completely disappears. Now what happens to the QRS complex? Now that is what, again, which is very dangerous. So what happens, you can see that the QRS complex starts increasing. It becomes prolonged. A prolonged QRS complex is one that is more than 0.12 seconds. So it keeps getting prolonged. And finally, what happens is the P wave disappears and the QRS and the T wave all merge together to form what is known as a sine wave pattern. So if you see a sine wave pattern, the potassium is usually 7.58 or above. And that is like having a ventricular tachycardia. This patient is primed for a ventricular tachycardia. So if someone presents like this, before even assessing why this patient has got hyperkalemia, you have to manage the patient. So just as we discussed, we give them insulin and dextrose. Why do we give dextrose along with insulin? Because when you give insulin to manage the hyperkalemia, they become hypoglycemic. So to prevent the hypoglycemia, you mix the insulin and dextrose and give it as an infusion in the first instance. Then if they are acidotic, you have to correct the acidosis. How do you correct that? You give them sodium bicarbonate intravenous and followed by oral if they're still not settled. Now, beta 2 agonists, especially salbutamol or Ventolin puffers, will again help in moving this potassium from the extracellular to the intracellular compartment. We don't want the potassium staying in the extracellular compartment because it irritates the cardiac membranes. And when the cardiac membrane becomes unstable, you start getting arrhythmias. That is where you use calcium gluconate. The calcium gluconate is something that we give for cardiac membrane stabilization to prevent arrhythmias. So that's the role of calcium gluconate. Again, you should remember when you're giving calcium gluconate, you should see whether this patient has had digoxin, because in the setting of digitoxicity, if you give calcium, you have to be careful because it can cause more problems. Resonium is a potassium exchanging resin. What it does is resonium acts over 4 to 6 hours. You will not use resonium as an immediate measure for someone with the potassium of 7 or 8. You'll give resonium when you've done all the other things. Resonium is a long-term thing. It maintains the low potassium by sucking up all the potassium from the gastrointestinal tract. So it's given either oral or per rectum. But your main emergency measures are insulin dextrose, correcting acidosis, using beta 2 agonists like salbutamol puffers or nebulizer, and giving calcium gluconate to protect the heart, basically. Subsequent management is to treat the primary cause. You need to find out why is the patient having. I mean, in 90% of the cases, it's renal dysfunction. So you have to find out why the patient has got kidney dysfunction, and you have to correct the renal dysfunction. If you can't correct it and the potassium still remains high, then there's no option but to dialyze the patient. You have to call the renal fellow and let them know that this patient has got acute kidney injury, hyperkalemia, dangerous cardiac arrhythmias. We stabilized it temporarily, needs dialysis. If there is metabolic acidosis, we treat it. And if you've identified some condition like this patient has just started chemotherapy, then you have to manage the tumor lysis syndrome. That's a different topic, but basically you have to hydrate them, you have to give them, correct the acidosis, and you have to give them continue using all the anti-hyperkalemia measures till the tumor lysis syndrome settles down. Rhabdomyolysis is a condition where the muscles break down. Like, for example, somebody's had been involved in a building crash or had a road traffic accident, and they have crush injury. Then what happens is the muscles break down, and again, it is a shift of the potassium from the intracellular to the extracellular compartment. And again, the key thing is to hydrate them and manage the hyperkalemia and correct the acidosis till the rhabdomyolysis resolves. So that pretty much is a short sneak peek into hypo and hyperkalemia, because this is a lot of information. You want to look at it from the perspective of an intern or a resident entering managing these patients in the emergency and trying to understand, because these are all issues which are managed in the emergency. And sometimes after the initial management, you'll get the help of the physician or the nephrologist. But in the initial case, in the initial instance, when you're taking history, and you can prep the patient, understand what is happening, manage hypo or hyperkalemia, and then you can call the physician, and then the physician will have a better handle on what is happening. So is there any question that you want to ask? Or is there, I don't know if I can open, I'll stop sharing the screen, then I can see my chat window, I think. Now I can see a chat window. So there is a question from Achaya. So why is the rate of IV potassium important, as why does it vary with central and peripheral line? So that's what I mentioned. So with the peripheral line, if you are limited by the risk of extravasation, and central line is a bit more it's a secure line, so you can probably give it a bit more faster. So you have severe reactions with the extravasation of potassium, and with central line you can but again, you should remember that if you have a higher rate of infusion, it needs to be, you will need monitoring. So depending on the rate of infusion, you will need a cardiac monitor, again, because you don't want to give it excess, you don't want to run the risk of hyperkalemia and cardiac arrhythmias as well. Okay. Okay. So if there is any questions, you can always post them to my WhatsApp through FIDA. I think FIDA is your representative, and I'm happy to answer that. Okay. If there's no more questions, then we'll close the session. Thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Bye.